Hello, I am Rebecca Millman, Associate Professor and Section Chief of Radiological Sciences at the University of Colorado School of Medicine. This brief presentation is going to give an overview of radiation and cancer risk. In the last presentation, I talked about deterministic risks or tissue effects. Here, I'm focusing on stochastic effects, otherwise known as probabilistic effects. Specifically, we'll look at what the relationship is between radiation exposure and medical imaging and the risk that this exposure will cause a patient to develop cancer. This can be a particularly tricky topic because while there are some things that we do know, there are others that we still don't know about radiation and cancer risk. Part of the reason for this is that the background incidence of cancer is very high. The American Cancer Society predicts that in 2021, more than 1.9 million new cancers will be diagnosed in the US. The lifetime cancer risk is high. It's about 40%. So how many of these cancers are due to radiation? That's the tricky part, because there's no way to determine if an individual cancer was caused by radiation exposure or from some random mutation. In 2006, much of what was known about radiation and cancer risk was summarized in this report by the National Research Council. The Beer Committee, an abbreviation for Biological Effects of Ionizing Radiation, looked at data collected from survivors of the atomic bombs dropped on Japan at the end of World War II. They also looked at studies of people exposed to radiation as part of medical procedures, studies that looked at the health of people exposed to radiation through their jobs, and environmental studies. It's important to note that this report specifically looked at low levels of ionizing radiation, where low levels or low doses is defined as acute doses below 100 millisieverts. This is relevant to medical imaging since almost every imaging exam performed has an effective dose below 100 millisieverts. The overwhelming source for current radiation risk models, however, comes from Japanese atomic bomb survivor data. This plot shows various radiation risk models. Risk, defined as the excess number of cancers in a population, is plotted as a function of dose above background. The first model, shown here in orange, represents hypersensitivity. This model states that low doses of radiation are more harmful than higher doses of radiation until a certain point where the risk becomes linear. The second model is a threshold model, which states that there's no risk from small doses of radiation until you reach a threshold dose. At doses above this threshold, risk increases with increasing dose. A third model is called the hormesis model. Hormesis states that small amounts of radiation are actually good for you and provide a protective benefit. At higher doses, there's a risk posed by radiation. The last model shown here is referred to as the linear no threshold or LNT model. This states that there's some risk associated with any radiation exposure and that this risk increases linearly with dose. It's this model that is typically used to describe radiation risk. It's important to note, however, that this model is based primarily on extrapolations of data from acute doses above 100 millisieverts. So let's look at this a little more closely. This plot is from the Lifespan study that's collected health information from survivors of the Japanese atomic bombs. This study's collected data from 94,000 atomic bomb survivors and 27,000 Japanese who were unexposed to radiation from the blasts. What this plot shows is the excess relative risk is a function of the dose to the colon. One thing you'll notice is that the dose on the x-axis is in units of gray. So the part of this plot that's relevant to medical imaging is a very small portion highlighted in yellow. If we zoom in on this part of the plot, what we'll see is that at these low doses, the relationship between risk and dose is extremely uncertain. An excess relative risk of 0 means that there's no elevated risk. And we can see that some of the data points here actually have an excess relative risk below 0, which would suggest a protective benefit at these doses. Even some of these data points around 100 milligray and slightly above 100 milligray show conflicting things. Some data points show an increased risk while others do not. In other words, the data at these low doses are extremely noisy. By looking at the rest of the plot, however, we can see that there seems to be a more linear relationship at higher doses. This plot is from a study that looked at 50 years of data from this Lifespan study. It shows the cancer rate as a function of radiation dose to the colon, shown here in milligray and presented on a logarithmic scale. But again, these data show that below 100 milligray, it's far from clear what's going on. In particular, this first data point, at a dose below 1 milligray, is from people not in Hiroshima or Nagasaki at the time of the bombings. In other words, there's no noticeable difference in cancer rates between individuals who were not near the bombings and those who were in Nagasaki and Hiroshima but exposed to doses below about 100 milligray. The BEER-7 report also looked at cellular and animal data. Cellular studies suggest that when doses are separated by 24 hours, the effects are not cumulative. They also suggest that at doses below 100 milligray, there's protective responses that are induced, but that this effect decreases at doses above about 200 milligray. In studies performed on dogs, their lifespan actually increased when exposed to small amounts of radiation at a low dose rate, about 50 milligray per year. Radiation exposure did not shorten the dog's lifespan until much higher dose rates, about 700 milligray per year. Studies into the effects of radon exposure also lend some insight into this discussion. The EPA limit for radon exposure in buildings is 148 becquerels per cubic meter. At doses above this limit, studies have shown a 34% increase in lung cancer deaths. But at lower levels, there's actually been a radioprotective effect observed. Another source of information is from studies of the health of individuals who live in parts of the world where background radiation levels are particularly high, several times higher than what they are even here in Colorado. Multiple studies have shown that in areas with higher levels of background radiation, the cancer incidence is lower than in areas with lower background radiation levels. There's also no evidence of increased cancer risk for those living near nuclear power plants. So what does the BEER-7 report say about radiation risk from doses below 100 millisieverts? It states that, quote, the committee judged that the linear no-threshold model, LNT, provided the most reasonable description of the relation between low-dose exposure to ionizing radiation and the incidence of solid cancers that are induced by ionizing radiation. Importantly, the report went on to say that, quote, at doses less than 100 millisieverts, statistical limitations make it difficult to evaluate cancer risk in humans. Needless to say, there's been quite a bit of debate about the legitimacy of the linear no-threshold model. 12 years after the BEER report in 2018, the National Council on Radiation Protection and Measurements published a commentary related to LNT titled Implications of Recent Epidemiological Studies for the Linear Non-Threshold Model in Radiation Protection. In their statement, this committee reiterated that the risk from cancer at low doses is small and may not be distinguishable from background risk. They also state that epidemiological data cannot justify using the LNT model to estimate cancer risk to populations who received very small individual doses. But they conclude that the LNT model should continue to be used for radiation protection purposes. And this last part is vitally important to understanding the applicability of the LNT model. Here, NCRP is specifically saying that LNT is a reasonable model to use when determining radiation protection standards. And it's important to clarify that radiation protection purposes does not mean radiation protection of patients. Rather, it means radiation protection of people working around radiation as part of their jobs and to members of the general public. It's actually these populations the ALARA mantra was created for. The idea of ALARA, or as low as reasonably achievable, was intended to describe an approach to radiation protection for workers and the general public. And you'll notice that even here, this term, very intentionally, includes the phrase as reasonably achievable, not as low as possible, but as low as reasonably achievable. In addressing what reasonable means in this context, economics and convenience were specifically mentioned. In other words, spending $100 to reduce exposure to the public from 1 millisievert a year to 0.1 millisieverts may be considered quote-unquote reasonable, but spending $100,000 for the same dose reduction may not be. Another example is lead aprons worn by fluoro operators. Wearing one lead apron will decrease a person's exposure by over 95%. There are trade-offs in terms of maneuverability and the weight associated with the lead apron, but that's typically seen as a reasonable protective measure. However, the orthopedic burden of wearing 2 aprons, which will decrease a person's exposure but only by another couple of percent, is less reasonable. And in these instances, where there's no medical benefit to workers from their occupational radiation exposure, this is a reasonable approach. So what does this mean for patient exposures to radiation? That's not addressed by this report. When it comes to patient radiation exposure, there's no limit. This is because there's an assumed benefit to the patient from each exposure to radiation. If there's no potential benefit to the patient, the imaging study is not justified. That's not to say that imaging has to yield a positive diagnosis to be considered justified. So why is there debate over the appropriateness of using LNT to model risk from radiation use in medical imaging? Again, the problem centers on evaluations of risks and benefits. For any imaging exam, the potential benefit to the patient should be greater than the associated risk. Sometimes these benefits are obvious. Determining whether a patient has bleeding in the brain is critical to determining the course of care for a suspected stroke patient. Sometimes it's less obvious, like when deciding whether to do a head CT for a patient who presents in the ER with a headache. Similarly, risk can be tricky to determine. For example, most people will think that the risk of doing multiple multi-phase liver CT scans on a pregnant patient puts the fetus at some risk. But what about doing a single-phase abdominal CT scan on a pregnant patient? What about doing an abdominal X-ray on a pregnant patient? Which of these procedures pose a risk that is still smaller than the potential benefit to the mother, and most likely, by extension, the fetus? And radiation effects are not the only risk that needs to be considered. For example, there's been a push to diagnose suspected acute appendicitis in children using ultrasound rather than CT because of the radiation used as part of the CT scan. But ultrasound also has a lower diagnostic efficacy, which increases the likelihood of misdiagnosing acute appendicitis in children. Analysis shows that risk of misdiagnosis is higher than the risk associated with the radiation used during a CT scan. Another example is the proliferation of replacing CT with MRI, especially in pediatric patients, as a way to reduce patients' radiation exposure. In this case, not only do we need to consider whether MRI will give adequate diagnostic information, but we also have to consider other risks. MRI, especially for pediatric patients, can require sedation, which carries its own risks. MRI also takes longer, and in trauma patients, there may be risks associated with a delayed diagnosis. There are also risks posed by the MR environment, including those posed by implanted devices or by the large magnetic field itself. So why is this a problem? It's obviously a problem if we grossly underestimate risks, but there's also a massive problem if we overestimate risks. One example that sticks with me is a conversation I had with an 85-year-old patient who had recently undergone surgery to repair an abdominal aortic aneurysm. His surgeon wanted to do a 3-month follow-up CT scan to look for leaky vasculature, and initially the patient refused the exam because he was concerned the radiation from the scan would cause cancer. So let's consider this for a minute. What poses a larger health risk to the patient? The 10 millisieverts of radiation he'd get from having the CT scan, or having abdominal bleeding that went undetected? Another example is radiation risk from mammography. I spoke to a woman just this last weekend who had her first mammogram after several years. Her primary reason for not having had more routine screening? She was afraid that the mammogram itself would cause breast cancer. Yet I think everyone listening to this talk would agree that the risk of getting cancer from a mammogram is much, 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 much smaller than the risk posed by a delayed cancer diagnosis. So where does this leave us? Multiple professional organizations, including the RSNA, American Association of Physicists in Medicine, and the Health Physics Society, have, over the years, issued statements that at doses below 100 millisieverts, there is no evidence that the risk is statistically different from zero. And this brings up another important point. It's nearly impossible to scientifically prove that something is safe. So I'm not going to tell you that small doses of radiation pose zero risk. But what I will say, what most credible scientific sources will say, is that if there is a risk associated with small doses of radiation, it's very, very small. And the doses associated with medical imaging are much lower than the amounts known to cause cancer. Okay, so I've been discussing stochastic radiation risk in general. But what do we know about risk to individual organs? 2 organs that are considered to be particularly sensitive to radiation are the thyroid and the breast. So let's start there. This chart shows data on the relative risk from radiation exposure to the thyroid in children. A relative risk of 1 indicates that there's no increased risk above background levels. The radiation dose here is shown in units of milligray. what we see is that, again, it's unclear what's happening at these low doses. For this data point around 25 milligray, the relative risk is below 1, indicating that the risk is lower than it is without any radiation exposure at all. But what I really want to point out here are the error bars, shown here by the red lines. These error bars represent the 95% confidence interval. So data points with error bars that cross a relative risk of 1, shown here by this dashed blue line, do not have enough statistical power to determine if there's any increased risk from radiation exposure. So when we look at these plots, we have to consider the error bars, not just the data points themselves. So these studies concluded that the data appear linear, but they mentioned that the data can also be accurately described by a threshold dose of 30 to 45 milligray. There's also a difference between internal and external exposures to the thyroid. Internal exposures, for example, would be from ingested radioactive materials, and external exposures is really what we're talking about with most medical radiation, from CT scans, for example. Also, with the thyroid, risk decreases with age. The lifespan study data show little increased risk for individuals who are exposed to radiation after about age 20. So let's look at the effect of radiation on breast tissue. We know that there's a dose dependence. At very high doses that we see in radiation therapy, for example, about 20 to 60 gray, there's a demonstrated increased risk. At moderate doses, between about 600 and 700 milligray, there's some suggested increased risk. At low doses, however, such as what we see in diagnostic imaging, we see mixed results. Some studies have shown that there's an increased risk, others have shown that there isn't. We know that there's an age dependence. The risk seems to be highest for patients who are exposed when they're under 20 years of age, and there may not be an elevated risk for patients above the age of 40. There's also a dependence on genetic variation. BRCA1-2 carriers who are under the 40 years of age may have increased risk. So again, there's still a lot that we don't know, but some of this information may have consequences for what we recommend for screening programs, especially for screening high-risk patients known to have these BRCA1 or BRCA2 genetic mutations. For lung tissue, there's no evidence of increased risk even at doses of 100 milligray. No evidence of increased risk among tuberculosis patients who underwent many fluoroscopy exams up to 8,000 milligray cumulative dose. So let's look at data for the liver. There's little evidence of risk for exposures before age 10 or after age 45. And again, we can see here that this plot shows excess relative risk. So here, there not being any risk above baseline would be an excess relative risk of 0. It's plotted as a function of the weighted absorbed dose to the liver in gray. So again, if we look at this lower end, it's really unclear what's going on. And it's really this very small portion that I've highlighted in blue that's relevant to doses in medical imaging. And there's just a lot of noise in these data, so it's really difficult to figure out what's going on. So I think we all know that radiation risk is a big topic of conversation in radiology and in the medical community in general. A lot of this was instigated in early 2001 when AJR published an article that estimated the risks of radiation-induced fatal cancer from pediatric CT. And this was one of the headlines that came out of this. There are these alarmist headlines that claim that 15,000 people will die from CT scans over the course of a year. So where do these numbers come from? Where does this information come from? It's not entirely bogus, but it's good to understand where it comes from. So let's look at this plot. This is from the BEER-7 report, and again, it shows excess relative risk of developing solid cancers as a function of radiation dose given here in sieverts. So if we look at what it is, what the risk is, the radiation dose of 1 sievert, or 1,000 millisieverts, we can see that there's an associated excess relative risk of about 0.6. So LNT, the linear no threshold model, states that if there's an increased risk of 0.6 or 60% at a dose of 1,000 millisieverts, then at 10 millisieverts, there's an increased risk of about 0.6%. So if we say, okay, there's 70 million scans performed in a year, then we can just do the math and say, well, we can conclude from this that there are about 420,000 radiation-induced cancers, and some percentage of those will be fatal. And that's where these values come from. But let's look at this a little more. So again, let's go back to these plots from the BEER-7 report. This plot shows excess relative risk as a function of the weighted absorbed colon dose, given in gray, and it shows data only for males. So again, we're really looking at the left side of this plot, but similar to what I mentioned previously about the error bars in one of the previous plots, I want to point out here that these red dashed lines, or what I've kind of highlighted here in red, represent the 95% confidence intervals. So we'll notice that on this lower edge, the lower bounds of the 95% confidence interval only crosses zero around about 400 milligray, or 0.4 gray. And this is important because, again, this means that below this dose, below this point of 400 milligray, we really can't say that there's any statistical evidence of an increased risk. If we look at comparable data for females, we can see that there is a slightly higher excess relative risk, but we still see that if we look at the lower bounds of this 95% confidence interval, it only crosses zero around 100 milligray. So there are a couple of last things that I want to discuss. The first is the idea of cumulative dose. And this is the idea that the dose from a CT scan performed today is affected by the dose that was from a CT scan that was performed a year ago, or a month ago, or 10 years ago, and that each subsequent CT scan adds additional risk. So this is a paper from JACR. It was an editorial that was written, and the author talks about how there should be limits for the number of CT scans that can be performed for a patient. And specifically, he's talking about patients coming into the ED, and he encourages organizations like the ACR or other radiology organizations to issue some sort of practice parameter that would allow physicians to have some guidance in terms of how many CT scans is too many. And this is problematic because it's not actually based in science. There's no evidence that the risk from a CT scan is affected by any previous radiation exposure. Now, in the last talk, I talked about how that was different for deterministic effects. So I want to emphasize that this is for stochastic effects. So in August of this year, the APM issued a position statement that says that they recommend against using dose values, including effective dose, from a patient's prior imaging exams for the purposes of medical decision making. Using quantities such as cumulative effective dose may negatively impact medical decisions and patient care. This was endorsed by the ACR, the Health Physics Society, RSNA, ASTRO, and some other organizations. And I mention this because it's really tempting to add up doses from various imaging studies and to try to assign some sort of risk. And it's even easier now that we can track all of that with computers and analyze all of these data. But there's not actually any scientific basis for doing so. The last thing I want to discuss is how do we critically evaluate journal articles that talk about radiation risk? And this is something that we're going to talk about in the in-person presentation. And I've posted the PDF for this paper online also. So this study was performed to look at cancer risk related to low-dose ionizing radiation from cardiac imaging in patients after acute myocardial infarction. So they looked at a little over 82,000 patients following myocardial infarction. They excluded patients with a history of cancer, and they used imaging doses from previous publications, so not patient-specific. And they looked at cancer occurrence in patients that had imaging versus cancer occurrence in patients that had not had imaging. And they followed cancer diagnoses cancer diagnoses that occurred 1 year or more after the imaging took place. What they found was that patients who underwent cardiac imaging, 77% of them, were more likely to be diagnosed with cancer within 1 to 5 years after the imaging procedure. They concluded that the relative risk of cancer is 3% per 10 millisieverts. So when we meet in person, we're going to discuss this a little bit more and analyze this paper in particular. So summary of stochastic effects. What we know. Large amounts of radiation can cause cancer. What we don't know, the effects at low doses, which I'm defining as below 100 millisieverts, and details about these dose rate effects. There's no known risk to staff because the doses are just too low. And in terms of risk to patients, the vast majority of diagnostic imaging exams and image-guided interventional procedures are performed using less radiation than when there is known harm of cancer effects. And lastly, here's my contact information if you have any questions or comments.